Thank you very much, and thanks very much for the opportunity. I'm going to be talking broadly in the context of achieving universal health coverage through national health insurance in South Africa, but more specifically on the role of regulation in driving quality through some specific work we've done with the South African government in setting up an independent Office of Health Standards Compliance. I'm South African. I work in a large DFID-funded program that HLSP manages in South Africa called the SARRAH program, strengthening South Africa's response to HIV and health. The main partner in the program is the National Department of Health, and we're working essentially on many of the Minister of Health's reforms in re-engineering of primary health care, competency assessments for hospital CEOs, establishment of a leadership and management academy, but also pursuing and providing support and lessons learned around national health insurance, which is a major reform that South Africa is in the very, very early stages of conceptualizing and considering. Excuse me. I noticed, just realized during the previous presentation how I can't say far behind, but where we are compared to where Ghana is, and there's just so many lessons to learn from that presentation. So it was really, really useful, and I'd like to talk to the previous speaker afterwards about getting her to come and speak to some of my colleagues in the Department of Health. Would be really, really useful. Just the outline of my presentation. Just want to talk a little bit about context of South Africa, but really focusing on South Africa's burden of disease, and secondly, the current health financing arrangements in South Africa, which will demonstrate significantly inequitable distribution of health resources and finance. And then very, very briefly just describe the broad structure for the proposed national health insurance in South Africa. My focus on the presentation is really on, as I said, on regulation, using regulation as a driver of quality. I'm not a health finance person or a national health insurance person necessarily, an expert there, so I'll just be touching on that very briefly. And then to look a little bit at this Office of Health Standards Compliance that we've helped the government of South Africa to set up, really its role in driving quality in both the public and private sectors, but more importantly how it will be used as a prerequisite for public health and private health facilities to be certified or licensed or accredited to be contracted to offer health care through a national health insurance. Then a reality check, just to give you a sense of some work we've been doing with the inspectors of this new structure, around 500 facilities, both clinics and primary healthcare facilities and hospitals, and where we are actually in terms of the standards that we've set and the compliance against those standards, and just to show what a long way we've got in terms of quality. And it just struck me earlier, coverage and access in South Africa is not necessarily an issue, and if it's not coupled with quality improvement, you'll have a country like ours who spends a significant amount of its GDP on healthcare, but has such poor outcomes. And then in the context of a developing country, to look at the advantages and disadvantages of a regulatory approach to, or quality enhancing mechanism, and then just some concluding comments. Just before I kick off on the context, I just wanted to lodge this presentation within some work which Dr. Professor Sue Leatherman, who I've worked with before earlier in our program, just to demonstrate that a regulatory intervention is not the be-all and end-all of quality improvement. It's really one spoke in a much bigger wheel of quality improvement, and I just wanted to set that up front, that I'm not pushing regulation as the sort of be-all and end-all of quality. It's really just one approach, but I want to share how we've catalyzed off that to increase the culture of quality improvement in South Africa. And she talks about some other quality enhancing interventions, patient-focused interventions, incentives, improving the whole data flow, the quality of data, and IT, organizational interventions, and healthcare delivery models, and I suppose also clinical care quality interventions as well. So that's where this fits into the broader quality improvement framework. So South Africa, the Lancet, as well as the Minister of Health, often talks about South Africa having a quadruple burden of disease with the four main areas: HIV and tuberculosis as a co-infection to HIV, maternal, newborn and child health, non-communicable diseases, and violence and injury. South Africa has a population of probably around 50 million now. In terms of HIV, we have 17% of the global burden of HIV and 5% of the global burden of tuberculosis. In terms of maternal and child health, we have about 1 million births, just over 1 million births a year, 1,600 maternal deaths, 20,000 stillbirths, 22,000 newborn deaths, and about 75,000 under 5 deaths, which is terrifying in many respects and really, really significant. The under 5 deaths are coming down thankfully through good PMTCT interventions in our HIV program. In terms of non-communicable diseases, we are 2 to 3 times higher burden of disease of NCDs than other developing countries. And then violence and injury, 2 times the global average for injuries and 5 times the global average for homicide. We've just had our Christmas period over in South Africa, and that means traditionally that a lot of people move from the inland down to the coast. And I mean, it's just been extraordinary, the number of road fatalities and road deaths that we've had. Speak up, yeah, sure. And obviously that puts a huge burden at this time of the year on health facilities and trauma units, etc. Okay, then just to talk a little bit about the current healthcare funding situation in South Africa. South Africa has a 2-tier system of healthcare funding. A relatively small but very expensive private sector, and then a fairly significant public sector. And there is clearly, as I'll just demonstrate through some of this, inequitable distribution, which really epitomizes the lack of universal coverage in South Africa. For example, a medical scheme member who's part of a medical aid through the private sector, about close to 10,000 Rand a year on average would be spent on a medical aid member, whereas a person relying totally on the public health service, about 1,925 Rand on average. But it's important just to have some caveats about that. First of all, in addition to the 9,972 Rand, there are significant co-payments expected of private sector members. I mean, I'm one, for example, myself, and I know that if any work that an anaesthetist does or anything, there's significant co-payments to that. And one of the problems is there's been no regulation of private sector funding in South Africa. So really the private sector it's been gay abandoned. They've just been able to charge whatever they like. In fact, there's a huge review. The terms of references have just come out in South Africa now, where the Competition Commission are going to be looking very closely at the private sector in terms of collusion of funding and pricing. And so that differential there is skewed by that aspect. There's also reducing benefits for private sector members, big tariff increases on a year-on-year basis. And then, some more to put this sort of into context. About 7 out of 10 South Africans, or close to 70%, rely entirely on public health services, whereas 16% of the population, are medical scheme members through medical aids. And then interestingly, there's another 16% in the population who can't afford medical aids and are not medical scheme members, but are nervous to use public health facilities for issues like visiting a GP or going to a dentist. So they just incur out-of-pocket expenses and visit private practitioners for those services, and that probably includes pharmacy as well. And but they will use the public sector in the case of an emergency or for surgery, but generally try to survive on out-of-pocket expenditure. And then just another sort of final way to sum this all up in terms of demonstrating the inequitable distribution. About 8.3% of SA's GDP is spent on healthcare, which is significantly more than the WHO standards. And I mean, if we consider the outcomes, as I said earlier, it's it's fairly glaring. Just under 50% of that money is spent on 16% of the population through the private sector, and then 83 or nearly 84%, just over 50% serves about nearly 84% of the population. And within that context, South Africa is the politicians, and rightly so, have committed themselves to pursuing a national health insurance to try to make the situation more equitable. We at very early stages, there's just been some very broad policy pronouncements through a green paper on how the national health insurance will be constructed in South Africa. We are waiting for a white paper which will give more instructive indication of how government sees the national health insurance unfolding. We have an election in South Africa coming up in May this year, so the release of that white paper will, I guess, be strategically linked to other political, the timing will be political. But essentially what we can glean from some of the early comments is, and the early pronouncements, is that it will be a pooling of public funds, general tax revenue, and an additional dedicated taxes, a payroll tax from employers and employees, those working in the formal sector, on salaries. There's also been some talk around the increasing the VAT rate in South Africa to make provision for this. This is very, very contentious, as I'm sure it is throughout the world who explores these kinds of things, and it's all very much on the fence at the moment. And then it's, the idea is to establish an NHI fund, which would be autonomous, would be, a public entity, autonomous decision-making, independent, and then to work on a defined minimum package of service for all. So you can kind of see where we are. We are way behind where Ghana is. But we have a complex environment with which to try and implement this. If you consider that nearly 84% of the population uses the public health service in the context of national health insurance, it's going to be critically important to improve the quality in the public service. And I'll just give you a sense of where we are and how we're doing. I mean, these issues around quality are probably common throughout most health systems, but are particularly significant in South Africa. And it's important to say that you can tell from what I've demonstrated in my previous slides that there is a large amount of money being spent by government on public health care in South Africa in terms of the GDP. So the money is there. We only rely on donor support for, I guess it's really just the main provider is PEPFAR providing ARV drugs. But essentially from that, I have the dilemma working in a DFID-funded program, is that often government do not spend their budgets because the donor funding is there, and rather than donors playing such a significant role in funding healthcare. So the money is there, but despite that, there are increasing concerns regarding the quality and the acceptability of care. And just some of the main causes of this which we're seeing. There's generally quite weak accountability in the system. Performance management systems tend not to work. People are able to get away with things without being held accountable, and consequences for actions. This is all tied up in a broader sort of political thing. Consequences for actions, sacking people, firing people is not really a commonplace. So that status quo remains. There's insufficient management capacity at all levels. It's a big problem for us. We've set up during this project a leadership and management institute for hospital CEOs, also funded a large review of qualifications and competencies of hospital CEOs, and we found wasn't an area I particularly focused in, but we found that a lot of hospital CEOs some of them didn't even have a medical background. They were appointed as they were teachers previously, or no offense to teachers or educationalists. I'm in fact one myself from my previous life, but really a need for good managers at the level of the district and in hospitals. Another big issue in South Africa as well is a weak primary health care system and referral systems. What tends to happen in South Africa is most people will bypass primary health care and go straight to hospitals, which causes a supply and demand issue in hospitals, puts a lot of pressure on hospitals in terms of waiting times, equipment, and you can imagine that. And then, of course, what it does as well is perpetuates a curative sort of model of healthcare, whereas primary healthcare should be the entry point where health promotion and preventative services are offered. But there is a massive drive by the minister to re-engineer primary health care, and we're very much involved in that as well. And then there's some external factors around human resources, which is a serious constraint. Private sector tends to offer a better environment and better salary levels for doctors. And of course, there's a major brain drain of doctors. Doctors are well trained in South Africa. They are sought after in other countries, particularly here in the UK, in Canada, and in other countries as well. So we have a big issue there. And then in the private sector, there are issues as well because it's unregulated. There's perverse incentives. There's generally a fee-for-service model, so the more patients you see, the more kind of consulting rates you get, and it's a kind of an in-out, a lot of prescribing of antibiotics and things like that. And then there's issues, as I've mentioned, around co-payments in the private sector. So in the context of all of that, what does the government do? Quality improvement is not non-existent in South Africa, but a lot of it has been driven by the NGOs at the district or sub-district level with a couple of facilities. Rather uncoordinated, driven by the funders' expectations. PEPFAR has been very much involved in this. Government decided they're going to take the leadership on this, and the way in which they decided to do that was to amend the National Health Act to create provision for an independent Office of Standards Compliance. Incidentally, we've done a lot of lesson learning, training, exchange programs with the Care Quality Commission here in the UK, and a lot of the basic tenets of our structure of our Office of Health Standards Compliance has relied heavily on that structure, but also the lessons that they have learned in the way in which they have implemented the CQC. The key objectives of the Office of Health Standards Compliance, just three. The main function is to monitor and enforce compliance with prescribed norms and standards. We've helped develop some very robust standards. These standards are not professional standards. They're just basic quality care standards. They are risk rated. We have three groups. We have a vital, essential, and developmental standards. Vital standards are like the patient will be in danger if these are not in place in your facility. Essential are less critical, but need to be in place, and developmental standards are more aspirational. So it's a kind of a continuum of improvement through the standards. The second objective of the OHSC is to monitor indicators of risk. These indicators are currently under review and development as an early warning system relating to serious breaches of norms and standards. So in other words, not to wait for an outbreak of something, but to preempt this and to have an early warning system in place. And then the final part of the OHSC, which is different to how it's run here in the UK, for example, is that the Ombudsman for Healthcare is part of the office, and so the public can lay formal complaints, and should it be appropriate, these would be investigated and disposed of within the Office of Health Standards Compliance, and that would be around breaches of standards that have maybe been picked up through inspections, but also through the public lodging formal complaints. Okay, and then this just to illustrate how the Office of Health Standards Compliance is a critical prerequisite for national health insurance. The Minister has made it very clear that a facility, if it needs to comply with standards and norms, and then it will be certified in some form to be contracted by this NHI fund to offer services. So at the moment it's being used to bring the public sector up to an acceptable level of care, just general focus on quality and quality improvement. But eventually, these facilities would also need to be accredited to contract to offer services through a national health insurance fund. How are we doing at the moment? We've conducted inspections and audits in 500 facilities, which is probably, we have about, is it 4,500 facilities in South Africa? Is that including hospitals? I think so, about 4,500. So 500 is what, someone help me. 10%. Yeah. You can see the ranges of scores. So if we just cut straight to the grand total of all hospitals, we have initiated a tool and a report that a facility would need 80% to be able to be accredited to offer services for national health insurance. Now that is hugely contentious as well, because obviously how high or how low you raise the bar in terms of what's acceptable standard of care, more facilities would do better. But we've made a call to keep it at 80%. So you can see that in hospitals, for example, there's a number of, the average was only 63%, as opposed to getting 80%. And in primary health care, it's a lot worse. It's at around 47%. I must say that I don't think we had predicted what serious concerns there were in primary health care in South Africa. And it's a very difficult thing. I think you said it earlier, is because you don't want to go to facility. A lot of the facilities will say, these things are outside of our control. We can't help it that we don't have staff. We've procured for equipment, but the district office is, so it's been a very, very difficult road. And I must say that we've taken the view right from the beginning, through my counterpart in the department, that the Office of Health Standards Compliance, we would try to market it and communicate it initially as an enabling mechanism for improving quality, and not a sort of draconian sort of you failed kind of and that has paid off significantly, which I'll share a little bit about just now. I said right at the beginning that regulatory interventions is one part of quality improvement, and I just considered what the advantages and the disadvantages of regulatory interventions could be in the context of what we've experienced in South Africa. I think one of the biggest positives is it's created a single regulatory regime for standards and norms in South Africa, and it's shown leadership from the National Department of Health. We had a lot of councils, pharmacy councils, other bodies moving in and out of facilities, conducting specific audits around pharmacy, etc. And this has allowed for one set of common national standards that these different bodies have bought into. And there's a reciprocal arrangement between these bodies, like Pharmacy Council, who have a much broader audit with us, who just look at a range of quality audits across our domains. Secondly, it has ensured that minimum standards are adhered to. So I think, at worst, even some of those vital standards, those life and death kind of standards that haven't been adhered to, that has been dealt with through this process. This regulatory intervention is not going to take care from acceptable to excellent alone. That is a much broader, more complex set of quality interventions and the correct kind of leadership and management within that to take that. But it does ensure a minimum standard. And then, of course, there is a legal base for consequences. Inspectors have to be allowed into facilities. There are sanctions if facilities are not up to scratch, and that legal basis does give some muster to a regulatory intervention. The disadvantages: it's very resource intensive and costly. We have at the moment 150 inspectors. They're all based in Pretoria, which is our capital city, I think. So, yeah. Still is. I live there. That's probably why I don't think it is the capital. Feel like the capital. They're all based there, so when they move to facilities, there's a lot of transport disbursements. They're out of the office a lot, and so it is costly. the third bullet down as well is that you require highly skilled inspectors, and I've walked with the inspectors through their training process. We put out adverts for inspectors. We got, because of the salary levels that we could offer, most of the response came from nurses and from allied health professionals, a few lawyers, but we haven't been able to secure the services of GPs or doctors or specialists, because obviously the salary level that we offered won't attract those kinds of people. But what it does result in is that good people leave the system to join the cadre of inspectors, which obviously can have eventually downstream will have some impact. It does foster malicious and procedural compliance. An inspection is an event, it's not a process. So we do have two types of inspections. We have unannounced inspections, and there one can really see the true picture. For example, in those kind of inspections, you will see cleanliness issues, waste management issues, waiting time issues, and then when you do an announced assessment, those are not the issues. But one digs a little bit deeper, you find some other problems. So it does lead to a bit of window dressing for the announced things, and one doesn't know after you leave what's kind of left behind. But our reports do provide a quality improvement report and plan. So we try not to just do a hit and run, but we do meet with management afterwards, go through it in detail, do have a quality improvement plan, and invite other players that can enact or operationalize or support the facility to implement that quality improvement plan. And then the last thing, I mean, the bar in terms of high or low is acceptable quality of care can be manipulated, by politicians, etc. So it can be used as a political tool, if not independent. And then just some final concluding comments. Many I've mentioned already. I think the purpose we're here today, but as I said earlier, particularly evident in South Africa is that universal healthcare focusing on expanding access and coverage while not addressing quality will have limited impact on population health. Regulation is only one part of quality, I've said, and regulation alone will not lift care from acceptable to excellent. And then my last point was just something that is an unanticipated outcome of all this work, and I think it's something that we should capture, is that we expected there to be resistance to this whole process in facilities, and it's had exactly the opposite effect. When we asked for facilities right in the beginning to offer to do self-assessments, and then for us to come in based on after the self-assessment, we were so inundated with requests that we couldn't even cope with all the requests. Facilities have come back to us and said, this is the first time we've had a set of robust standards with integrity that we can measure our performance against. The request to do self-assessments on those standards has been significant. So for me, regulation can start or close the cycle of quality improvement along with all of those other interventions. And as I say, that was an unanticipated outcome of all of this work, and one that was greatly pleasing. And so we'll see how it goes. Thanks very much.